And remember that we have to sign in twice if you're a nurse, radiology tech, podiatrist.
What if there was a way to deliver rapid, safe, and effective hemostasis? What if your patients could ambulate quickly and have a better overall patient experience? What if you could do this without an implant and implant-related complications? Now you can. The new standard in access is Axera, implant-free, natural self-sealing access. Axera Access creates a long, shallow angle arteriotomy that delivers significant tissue-on-tissue overlap, producing a rapid and secure closure without an implant. Axera Access will improve your patient comfort and satisfaction, leading to improved throughput. Come see for yourself the new era in access, Axera Self-Sealing Access. What if there was a way?
All right, if everybody could get settled in, we're going to go ahead and get started with the afternoon session, complex endovascular techniques. At this point, we're going to really start getting into the nitty-gritty, sort of what I talked about this morning, the do-it-yourself sessions, the step-by-step sessions, the practical part of CVC, where we really get into how you do, how to get through a lot of total occlusions, how to use balloon angioplasty, how to use wires. I'm going to ask Dr. Craig Walker, one of the pioneers and masters in endovascular intervention and the course director for the New Cardiovascular Horizons, to start us off with this session with Zen Master Technique, how to wire a complex infrapopliteal CTO.
Thank you, Jaffer, and thank you for the lovely privilege of being at this great meeting. I have these disclosures, none really relative to this talk. But why should we talk about guide wires? Well, we access lesions, we cross lesions, we use these to facilitate the delivery of interventional devices. And why is this important? Well, obviously, if you can't access the lesion, you can't cross the lesion, and you can't get your devices to and across the lesion, then you simply cannot treat the patient. So guide wires play a really important role. And yet when I ask physicians, why do you use a given guide wire, most of the time they go, don't know. It's something I'm used to. So I'm going to try to give you some ideas about why you want to choose one over another. And there are a lot of things that we have to take into account. These are many of the things that we have to consider. And we're going to break these down. Now, all guide wires, I don't care which guide wire you're talking about, have the following things. They have a functional diameter. Historically, most of those we use in the periphery are either 0.35, 0.18, or 0.14. That is the core diameter. There's a core material. There is a core taper to allow for flexibility. There's a tip style. There are coils and covers, and there are coatings. And we're going to talk about each of those. First, the core material. Well, right now, presently, we have different materials that the core can be made of. Originally, wires were all made of stainless steel. We now have an improvement on that. High tensile strength stainless steel. This has much better torqueability. It has much greater strength. We also have nitinol wires. Nitinol hold their shape. There's a heat-sensitive nickel titanium alloy. And finally, we have coupled titanium with stainless steel to use, and also with super tensile stainless steel to harness the attributes of all. I'm just a little bit short to see over this podium and to see my monitor. Next, we have the core diameter. Now, the core diameter determines the stiffness of a wire, the torqueability of a wire, because given the same material, the greater the core, the more torqueable will be the wire. But here you see the charts looking at stiffness based on diameter. And you say, well, how important is this in terms of device delivery? Well, relatively minuscule changes in diameter have huge impact in terms of columnar shaft strength. An 014 wire is 2.73 times less strong in terms of columnar shaft than an 018 because it's related to the fourth power of the radius. So large diameter is going to always give us better rail support and torque, and it may enable vessel straightening and sheath placement in tight bifurcations. Smaller diameters will be more flexible and track better through a wire. And ultimately, we have to be able to deliver devices. What about core taper? Well, we have the basic core grind, and then the wires ground smaller. This simply makes it more flexible. We can have one or more of these. These can be broad and gradual, or they can be abrupt. These determine transition zones and support. And we can read these, as on this chart, which most physicians throw away very quickly, and it tells us about the wire. And so what this wire is telling us, this zone, is if you want to be on the stiffest part of the wire to deliver your device, it should be 15 centimeters distal to the area that you're trying to treat. That will put you on the stiffest part of that wire. Next, we have tip design. Tip designs can either be where the core extends all the way to the tip, hence called core to tip, or where it stops short of the tip and we're simply left with a shaping ribbon. Why would you use one versus the other? Well, in the periphery, we typically use core to tip. This gives us better force of transmission, better steerability, better tactile feedback because there is no cushion, and it tends to be a bit more durable. Why a shaping ribbon? Well, those are shaped more easily, and so we can go around very acute bends. They're flexible, and they're not apt to injure the distal vessel. We can prolapse these very easily, and we have to keep in mind they're more delicate. We all talk about gram tip strength of a wire, and I think it's important you understand what this is. This is penetrance. And what gives us penetrance? My background was that of a physicist, and I will just tell you, everything I look at in terms of physics. And it's pressure. Pressure is force per unit area. So what determines tip stiffness or gram penetrance is how stiff is the tip divided by the area of the tip. So you can give greater tip penetrance by either making it stiffer or by simply decreasing the cross-sectional area. We have coils and covers, and these affect support, steering, tracking, and visibility. They impact the dimensions of the wire, and they give us tactile feedback, which may be crucial as we're going through long total occlusions. We also have guide wire covers. These are actually sleeves which go over the wire and are not to be confused with coatings. And these provide lubricity. These can be hydrophilic or hydrophobic. We often combine coils and covers to give us an ideal mix match of visibility, ability to get through a lesion, and have some tactile feedback. And then finally, we have coatings. And we can have hydrophobic coatings, which are wax-like surfaces. They require no actuation. We often put these on the outside of wires so that devices will track more easily. Or they can be hydrophilic. These create a water-water interface, which gives us a coefficient of friction roughly similar to that of an ice skate on wet ice. That is an incredibly low coefficient of friction. So as we do these, we're trading off lubricity for tactile feedback. And you must make that decision a priori. Now, as important as the wire we use is how we shape it. If we want to really penetrate a total occlusion, then we want a straight or a very small angle at the very distal tip. If there's a lot of tortuosity, a secondary bend will assist us in getting around that. And if we're considering using a subintimal approach, we may make a bigger bend to facilitate the formation of a loop. Now, when you think about how guide wires fail to cross, there are a lot of things that can happen. One, the wire may prolapse at the cap. What can you do? Well, you can either use a higher penetrance wire, or you can use a shorter and sharper tip, or you can advance a support catheter much closer, which will enhance tip penetrance. Next, the proximal segment of the tip may buckle. Well, then you can use a wire with a higher tip gram load, a hydrophilic coating so that it will slide through more easily, or you may advance a support catheter. The tip enters the lesion and the wire fails to follow. You can use a wire with a higher rail support, a lower profile system, or a hydrophilic wire. And finally, the wire crosses, but the device fails to cross. You can use a wire with a higher rail support or a lower profile system. Now, using the wire, again, as important is how are you going to approach the lesion? Are you going to use an antegrade or a contralateral approach? Sometimes this is determined for you. Steep bifurcations, morbid obesity, bifurcating stents, aneurysm repair, prior aortobifemoral bypass, disease involving the origin of the SFA may all preclude antegrade approach. But if you need torque, if you need better force of transmission, many cases if you need the reach, what you need is an antegrade approach. Transcollateral pedal arch reconstruction can be useful in pedal artery access. When possible, I always try to use an antegrade femoral approach. I advance an 035 support catheter, diagnostic catheter, or sheath just proximal to the occlusion after I've treated any proximal disease that may be occlusive. And I do this because it allows better visualization with less contrast. It allows me to get a good roadmap. And when I take this roadmap, I make sure I get collaterals out of the way. I then approach the lesion with small wires and, if necessary, with backup support catheters. I use wire escalation technique, going to stiffer and stiffer wires, and I make sure that the tip moves freely. And one of the real keys here is to use quarter turns, not to spin the wire, and to occasionally pull back on the wire. If you're very trapped, you will feel resistance as you pull back on the wire. We use liberally nitroglycerin. We never force the wire. This is a very gentle technique. We always inject distally via the guiding catheter to ensure intraluminal position. We then exchange for a wire with a soft tip but good columnar support to deliver devices, and we place the wire as distal as possible to avoid loss. Now, obviously, the transpedal approach is something I've been doing for about 15 years now, and it has a lot of advantages. It lets us cross lesions, but we have talks on that. What about transcollateral? So there's some people you can't do transpedal, like this 49-year-old diabetic, rest pain, ulcers, cellulitis from the recent surgery she's had. And here you can see infrapopliteal disease. This has been attempted by great operators in antegrade fashion, could not do it, couldn't stick this very infected foot. So here you see a transcollateral approach. We're going to go through the collateral. I'm going to zoom through this. Here you see us coming up. You'll see the wire start to spring as it goes through these first little wires. I'm not advancing. There we are. So here goes the wire up. And as often the case, as we see often in transpedal approach, the wire is going to cross very easily in this case. And so here you see what before looked tough crosses quite easily. We then are able to externalize the wire, steering it back into the sheath. Once we've done this, we externalize the wire, we treat with a balloon angioplasty, and hopefully we will have an angiogram here showing you the outcome. Now, we did this live during our course in the past, and then off camera, that was 20 minutes, we'll treat this distal lesion. We actually then came through the foot up and we fixed the posterior tibial artery, achieving, apologize, I'm not advancing correctly, achieving nice three-vessel flow. What about pedal arch reconstruction? Well, there are typically connections between the dorsal and the plantar arch, and we can utilize that to treat patients when we see no foot vessels. This is limb salvage technique, typically antegrade access. I like to use floppy wires, and we go down one vessel and up the parallel vessel. So either down the AT and up the PT, or vice versa. And then we use long balloons inflated at low pressure. Here's one such case. Severe disease. Again, this was not a case where it was considered appropriate for pedal access. That is in this case, this is not one of the better results, it's just one of the most recent ones I happen to have a picture of. So we have the perineal filling here. So we're going to come up, we're going to wire the perineal coming backwards. We will now use long balloons, and we will take an angiogram here. And now we've filled a foot that didn't fill well before, and you can see how this looks side by side, pre and post. So treating complex lesions can be challenging. Wires fail in many ways, but I do not believe wires fail in 80% of in 20% of CTOs, as is historically reported. I think familiarity with a multitude of wires can benefit in these cases, and understanding technical wire attributes will make you a better interventionist. I thank you for your attention.
Thank you, Craig. So the next talk is going to be a talk on pedal intervention. And the title of it is The Pedal Revolution from Exotic to Routine. So, every time I open a magazine, they say, pedal access and, it's so exotic and crazy and things like that. And when that happens, then you're not really going to really pursue this, and you think it's so unusual. But what we do is, I'm going to give the talk, and then you'll do the ultrasound afterwards. Okay. So if you want to, what I want to do is I want to make pedal access a routine part of your practice. And I see pedal access kind of like I see radial artery access. Back in the day, we would always do femoral artery access, and people didn't want to really get into the radials, but then people started doing it, and it's, a routine part of our practice. I see pedal access the same way. So once we get our slides rolling here, and, I started doing pedal access, 4 or 5 years ago, and, Dr. Walker and McNamara, these guys have been doing it for quite some time, and, it truly has progressed. And the nice thing about it is now we have the equipment, we have the tools, we have low-profile sheets, we have devices that are really, really allowing us to go further and further, as Dr. Walker mentioned, going down transcollateral with lower-profile balloons and sheets, and the wires that we have now that are truly able to give us access and really get through these chronic total occlusions. So, initially when I started off doing pedal access, I did it for limb salvage patients, and we did it in those patients that only had infrapopliteal disease, and then we slowly, as you get more and more comfortable, we do it pretty routinely now in even our SFA stump occlusions. So why pedal access? As I mentioned before, it's an essential part of any limb salvage program, because at any point you're going to have infrapopliteal disease, you're going to have disease that you can't get to for certain reasons, so being able to use a different access is essential. In patients that have osteal below the knee, anterior tibial occlusions, for example, or a lot of collaterals that, your wire keeps going into the collateral vessel, so it's very helpful. As I mentioned before, for SFAs, osteal SFA occlusions, popliteal occlusions, and we have some examples as we go through here. So here's an example of an osteal SFA occlusion that, is very difficult to get into. You could, look at your ipsilateral ostium of the SFA and see where that comes off, and that can kind of help you a little bit, but this is really, really challenging, and if I see something like this, I just go straight for pedal access. We don't even mess around. Another example on the right-hand side is an anterior tibial artery occlusion that is helpful. So in terms of access, where can you access? So you can access the dorsalis pedis artery, and this is probably the best place to start. So if you're getting new to pedal intervention, DP access is probably the best place to start. And then posterior tibial artery access is also a great way to go. You have to move the patient's foot just a little bit to kind of orient it in a manner that you can get access, but it's also another good option. Peroneal is done. I don't do that very often. It's a little bit more difficult to do, especially if you're, in order to gain hemostasis, you really have to be confident that you're going to be able to get through that occlusion and then balloon it and to balloon tamponade it, or else it gets a little bit tricky. Now, in terms of methods of access, I started off doing my access angiographically, and it's not a bad idea to do it angiographically at first, especially if you don't have good expertise in ultrasound guidance. So angiographic access, we're comfortable with, we know how to use it. The nice thing is you don't really have to have any ultrasound experience. The problem is there's a lot of radiation use, and you're going to radiate your hands, as well as contrast use, because you're injecting the artery, you're really putting your needle on top of the artery and trying to gain access in that way. And you're only able to visualize the artery in a two-dimensional plane, so that makes it a little bit more challenging. So maybe you're in a vein, maybe you're in a different place that you really don't want to be. And so patient movement also takes place here. And usually if I'm going to do it angiographically, I would really I recommend putting these patients under general anesthesia, because even one slight movement, you're going to have your roadmap and it's going to go off kilter and you won't be able to get access. So this is an example of an angiogram of where you see a sluggish flow into the dorsalis pedis artery. And then on the left, or actually, you're right. Here you see access, so access in the dorsalis pedis artery. And the key here, the reason I'm showing this slide is I want you to look at that wire. Look how free that is. It's just, just really free, going really easily. That's essential, because if you dissect at this level, you're done. Just go ahead and stop the procedure, pull everything out, and call it a day. You really want that kind of access. Now, Dr. Pop is going to go over the ultrasound guidance and sort of what do you look for in an ultrasound access for pedal access, but this is just a quick slide to show this is a dorsalis pedis artery. This is what it's going to look like. You're going to have the artery in the middle and two veins on either side. The advantage of the ultrasound, as I mentioned before, is you get three-dimensional interpretation of the vessel and the plane that you're in. You can access the artery without any radiation or contrast exposure. And obviously the disadvantage is the ability, if you know how to use ultrasound. The way I started off is we just had our local, our ultrasound tech come in. She would do the ultrasound for me, really show me where everything is, and then I would gain access. But the most essential part is that eye-hand coordination. Because remember, these are 2-millimeter vessels, and then just that eye-hand coordination of trying to get that vessel. And what really expanded my ability to do this is starting when I started doing veins, because obviously with veins, venous access, we do that for outpatient intervention. Obviously, you can learn that next door. So in terms of tips for successful pedal access, the enemy is spasm. The enemy is thrombus. The enemy is dissection. These are the three things that you really want to look out for. So you're going to pre-treat with nitroglycerin intraarterial. I'll also give intravenous papaverin. That lasts a little bit longer. Some people like to give verapamil. I don't. I just stick with papaverin and nitroglycerin. I do that right before I get access, so I'm really vasodilated nicely. I use a short micropuncture needle, and usually they don't come in that kit. I usually specifically ask for that because then you can really brace your hand on the foot as you're getting access. Once you see the blood coming back, flatten out your needle, because again, these are very small arteries and sometimes you can be up against the posterior wall of that vessel. So you really want to flatten it and just try to advance your wire. You want to make sure absolutely that it moves freely, and then you confirm that with ultrasound guidance. So on the left-hand side, you see an image of the short micropuncture needle in the dorsalis pedis artery. On the right-hand side is the same angiographic image of the really mobile and free-floating wire in the dorsalis pedis artery. And again, you can confirm this with ultrasound as well, but I just like to use angiography for this. Once you do this, then you take out your needle. So you have your 018 guide wire in, you take out your needle, and what I use is I use the inside of the micropuncture, the inside of the sheath, just a dilator. And so, because again, what I'm trying to do is I'm trying to stay as low profile and as small of a hole as possible. So I insert the dilator of the micropuncture of the sheath, and then at this point I make a decision. I'd say, okay, is this going to be an easy, straightforward, flip the wire, come back down, or do I want to pretty much work from pedal access? If I'm going to work from pedal access, I'm going to go ahead and put in a sheath at this point. So I'm putting in a 4 or 5 French sheath, depending on what I'm going to do, and I'm going to go ahead and work from that access. Usually I'll have a sheath up and over, and if I just want to get through the chronic total occlusion and just get my soft end of the wire down and then do whatever I want to, atherectomy or stent, then I just go bareback. So this is an image of a trailblazer in the dorsalis pedis artery. You go ahead and insert that. I usually use a 018 wire, and then you try to cross your occlusion. At this point, you're going to go ahead and anticoagulate. I go ahead and, whatever you like to use, I use heparin. That's a better idea than to use Angiomax, but, whatever dose you usually use. And then here's an example of a patient that had a popliteal occlusion. I thought I could actually cross at antegrade. I wasn't able to cross at antegrade. So I brought the patient, at that point, what I did was, what I was doing, I was getting into some collateral that I couldn't recognize on the angiogram. So I did a pedal shot, and I brought the patient back. And we gained access to the dorsalis pedis artery. There you see the wire is floating really nicely on the left. Then I do an angiogram. That's where the occlusion is. And so I have a support wire, and this is a support catheter with the V18 wire. And just look at the difference. I mean, it's really incredible to see the soft end of the CTO is usually on the inferior portion of the CTO. And then here what we do is on the right-hand side, we snare the wire because you have to externalize the wire so that you can flip the wire. So here you have a demonstration of snaring the wire. It's not always that easy. It's a gooseneck snare, grab it, and pull it out of the sheath. Now, alternatively, you can use a capture device. This is one of the new devices. This was just an angiogram from a case I did the other day. It's a pretty slick device. It's basically a reverse cone that sits in the artery. This was an SFA, and so you dilate the balloon proximally, and it sort of tethers the device within the artery. And then it just very self-explanatory. It just goes up. The reverse cone just guides it into the occlusion, into the catheter itself. So it's pretty self-explanatory, and it's a really nice device. I think it's made by Spectranetics. Then what you do is then you have to externalize the wire. So you completely remove the wire from the body, and you have your trailblazer you also push out. Then you take the wire completely out, and then you put the soft end of the wire through whatever your end hole catheter you're using, Trailblazer or CXI catheter. And that's the key. Now you have soft tip of the wire in the pedal artery. And so now you see the sheath is there, the soft end of the wire is in the pedal artery. Now we're set. Now we're golden. Now you can pull the sheath out. You do whatever you want to. You can hold pressure. That's usually what I do. Even if you're fully anticoagulated, it's a tiny hold. You hold pressure for about 5 to 10 minutes. That's why we have fellows. We have a fellowship program, so they hold our pressure. Or you can balloon tamponade it. You could put a blood pressure cuff. This is not that big of a deal. So, some people are very apprehensive about this. Once you get through, you have soft end of the wire through, you're golden. And so this is that same case. We got through it. We angioplastied. We put in a couple of IDEV stents and had a great result. Now, they're not as easy as that all the time. So here's another case that we have pedal access. We come up and go subintimal. And it's going to happen. It's inevitable. At some point, you're going to go subintimal. So at this point, what I did was I brought in another wire from up top, because now what you've done, you've created a channel. So I have my end hole catheter. I've created a channel. You can angioplasty that channel as well, and then that just widens out where the hole that you're creating, and then it makes that one edge a little bit softer, and then it allows you to go antegrade as well sometimes. And this is an example of that, how you can sort of the theology or the theory behind how that works, and it's a kissing technique. The other really nice thing is now we have re-entry catheters that are low profile. Covidien makes the anterior catheter, which you can put in through the foot, pedal access, and has completely changed how I practice, and gives you a lot more confidence to cross SFAs. You can get into a CTO, into a subintimal plane and common femoral, for example, and allows you to get back in pretty nicely. And so this is after angioplasty. This is a little dissection there, but that will heal. Things like this, I just leave alone, and I just watch it. Enemy of good is better in peripheral vascular disease, and this patient ended up doing well. This is an example of a SFA CTO, as I showed you before. And as you can see, it's a stump occlusion. I knew it would be challenging to get through. from an antegrade approach, so we came retrograde. And this is actually an 035 system, so you can actually upgrade. You can go to an 035, and I do it all the time when I'm going through a CTO of the SFA. So this is a 035 Trailblazer with the soft angle glide wire. And here you see we're coming upon the ostial stump of the SFA occlusion. And luckily it popped in pretty easily. As I mentioned before, if you have a problem here, you can use one of the newer re-entry catheters. And this is where you really want to make your loop really small so you don't extend that dissection plane. You just take your time and you pop through. And then again, we had the same technique. We used a capture device or a snare and externalized wire and removed the wire completely from, and externalized or removed it completely from the artery. And then here we did a hawk of the left SFA. This is a LXC, I believe. And that's our results. It's balloon angioplasty. Know how to get out of trouble. Minimize your pedal time. That's usually my concept, is get in and out as soon as possible. As I mentioned before, spasm, thrombus, make sure you give nitroglycerin and papaverin if you have it generously. Avoid dissection by making sure your wire is nice and free. And that should really, really help and allow you to change this exotic procedure into a very routine procedure in your cath lab. As I mentioned, try to get good at ultrasound guidance, even if you're just looking at arteries early on and without doing any access. Really, if you can get that eye-hand coordination down, it'll really help. So learn this technique, use it frequently, join the revolution. The next there's a little change in the schedule. Dr. Andre Pop is going to be discussing guide to ultrasound access in the pedal arteries.
Hi, thank you. I couldn't agree more. I think the key to ultrasound access, if you haven't been trained in it, is start using it in big vessels that you're familiar with. Start with a common femoral and use it in every case. And after a while, you'll get very good at it, and you'll use it to stick anything you can think of. And the venous side is what really got me into this, because when you stick everything out of ultrasound, and for the past 2 years, I think I've stuck 1 or 2 arteries without ultrasound. I stick everything with ultrasound, and you can stick things that you would never dream of sticking before. So it's fun. So anyway, this is what we're going to talk about real quick. Very important to know your anatomy. You know, no point in trying to access the dorsalis pedis if the dorsalis pedis is occluded and calcified and it's not there. So my program is very, very CT heavy, and we use a ton of CT before we do these cases. However, for people who are heavily calcified, diabetics, end-stage renal disease, the CT may not help you very much for runoff. So it's really important to start with a catheter from above to give you an idea that there's something there to stick. Ultrasound can help you too. I mean, you can see by ultrasound that the artery is patent. The problem is, where does that artery go? And you need to be aware of variance, because a lot of times, you know, the peroneal may be what gives the dorsalis pedis or the distal posterior tibial. There's variance, and you want to know that before you get in, because if you're dealing with a TP trunk occlusion and you're accessing a vessel that doesn't go there, it's not gonna help you. Or if the occlusion is in a low popliteal and you have a variant anatomy of the AT, let's say, from the high popliteal, again, it's not going to help you. So you need to know where the vessels are. As it was already mentioned, the best site is in the foot. You can stick the calf, but I do that with trepidation, and it's not always the easiest thing to do. These are examples of variants. You know, at the top left-hand side, you see a posterior tibial that comes off as the first branch of the popliteal. On the big picture there, you can see that on one side, the anterior tibial is actually small, and the dorsalis pedis is given off by the peroneal. So you need to know this before you start accessing things. And ultrasound in a foot is great, but even if you use a lot of ultrasound, it's pretty tough to follow these vessels all the way up, and unless you have your technician with you. Generally, the ultrasounds that we use for this have very little penetrance, like the SiteRite. They say it goes to 6 centimeters. By 4 centimeters depth, you start losing any definition. So you really want to have a good ultrasound if you're going to do stuff higher up. It's important to kind of know where things go. I'm not going to belabor this. This is important because if you're trying to stick stuff in the calf, this is what you need to know. And CT helped me tremendously here to learn the anatomy properly. It's important to know what your compartments are, because if you get into trouble from below and you perforate, it's going to ruin your day, and it's not going to make for a happy patient. This is why we care about compartments. That's, I think it's called a Stryker device. They use it to measure intracompartment pressure. It's not a device that you want to see used frequently. The reason you don't want to see it used frequently is on the bottom there you see the incisions that the surgeons make to relieve intracompartment pressure once you have a compartment syndrome. And this is the happy result that you get when that happens. So patients are not going to love you if you have a compartment syndrome. This is a few things about compartment syndrome. Motor loss is late, so don't wait for them to lose motion. If they have pain out of proportion to what you see, if the artery is open and they're having more pain than they should be having, you need to think compartment syndrome, because otherwise you're going to end up with people who have muscles, have bone, but they can't move the leg, and again, they're not going to be happy. The diagnostic criteria are at the bottom, based on pressure and based on differential pressures. So how do I access the foot? Positioning the foot is very important. If you were going to access the dorsalis pedis, basically you put the foot top up and it's fine. If you want to access the posterior tibial, you invert the foot a bit. You can do kind of an in-between position and access both. The problem a lot of times is people put the legs too close together. You need some room to put your equipment, so you want the legs spread out a bit, at least the feet spread out a bit. The short needle is crucial because the standard micropuncture kit comes with this big, long needle that's great for the groin. However, the problem is these are very small arteries, and on top of that, they tend to be depressurized because they're fed by collaterals. So if you have a 10 centimeter needle, it's going to take a while for that blood to make its way back to you, and you may be in and out of the artery a bunch of times before you've dissected it and you've terminated your procedure. So Cook actually has a 2.5 centimeter needle that is part of their 6 French radial kit, but you can also buy it separately. And that's the cat's meow for accessing the foot, because it's very short and you get flashback right away. Fluoroscopy guidance, I used to do it a lot. Now that I switched to ultrasound, hair is growing back on my hands, so it's a wonderful thing. You want really to use ultrasound if you can. I personally don't like the wires that come with the kits. I don't like the 018, 023 wires. I find them too stiff, and they're also short. So generally, I access with a coronary wire, something like a short beamer. That doesn't have to be the wire that you're going to use to cross your CTO, but I access with that wire. Movement of the tip is crucial, and then over that, I exchange for something else, like a short support catheter, or then you can exchange for a sheath or whatever. And it would be nice if a company made a 014 short catheter. The shortest right now I think is 150 or 135, which is kind of difficult to use for this purpose. Ultrasound landmarks. So generally the arteries are sandwiched between two comitant veins. That's not always the case, but it's the case most of the time. if you see something that's pulsatile and it doesn't have two comitant veins, there's going to be a collateral. You can stick those, there's nothing wrong with sticking those, but they tend to be more into soft tissues and they tend to move a lot. But you can access them if you want to and if that's the only place where you're going to get into. The other way to know that it's an artery, you have the calcifications, the plaque. The veins can calcify and have plaque as well, but they do that much less. Pulsatile flow on Doppler, and the main thing, you press gently with the ultrasound. Pressing gently, the veins collapse, the artery doesn't. You see some pulsatility, you know what you're dealing with. This is the foot of one of our techs in the lab who was so kind to let us ultrasound her. And you basically see the artery in the middle and you see the two veins at the side. There's two ways of doing this. You can do it short axis, which is what I'm most comfortable with, and most people are most comfortable with that in the beginning. Or you can, you can follow it up as we're doing here. Or you can switch to a long axis view, which is very cool, and if you're good at it, it's a wonderful way of doing it. So these are further pictures. You see there's a little spot of calcium in the artery right in between the two veins there. And you can track it until you find a nice place to access. The other nice thing for ultrasound is you can avoid all sorts of hidden traps, little dissection flaps from a prior intervention, little calcifications, plaque that you don't want to stick in. You stick exactly in that 2 millimeters of vessel that's nice and normal. So these are, again, looking at the posterior tibial. Talking about peroneal or accessing the calf vessels. See the anterior tibial in between the two bones, superficial. If you need to stick it, it's not going to be that difficult. Posterior tibial, posterior, not that difficult to stick. But look at the peroneal. Peroneal is generally covered by the anterior tibial, especially as you go further down. So either you go posterior to get a peroneal, or if the AT is occluded or is not there, then you can stick in between the bones. But there's a lot of variability in the amount of space in between the bones. So this is one example where actually you may be able to go straight down there and get it. But in this case where actually everything is nicely occluded, these are pictures from our CT scanner. Look how little space you have between the bones, and you're never going to get this in between the bones. You may get the peroneal on the right side of the screen, maybe past the posterior tibial, but you're not going to get it between the tibia and fibula. So knowing where things are is very important because there's a tremendous amount of variability. And again, peroneal access, not something that you want to do in the beginning. I do it rarely enough and only when it's necessary, but it can certainly be done. You need, however, generally better ultrasound than the usual one you have in the lab. For peroneal, I actually call the tech to come up. Everything else I access by myself. Another example, we're not going to belabor this. This is the micropuncture pedal access kit, again from Cook. The one thing I'll caution you, they're listed as 5 French. That is a 5 French catheter size. They're not a 5 French sheath size. So if you're trying to get a 5 French compatible, like a 5 French glide catheter through this kit is not going to go. It's really, inner diameter is like 2.9 French or something like that. These are the 2 wires, the 2 needles that I used. In the left upper corner is the 2.5 centimeters. That's great. It's perfect for pedal access. 4 centimeters is something that you may use for calf access. And in the middle, there's a short, actually, floppy platinum tip guide wire that's like 60 centimeters. And it's nice because it allows you to basically have a bit more control. The problem, as I said, I prefer BMW wires or coronary wires for the initial wire on access. Now, we've gotten access, great, we high-fived everybody. What do we do next? Generally, I stick to small devices in the foot. I oftentimes go sheathless. You can go with a sheath, but you have to make sure that your device obviously fit through the sheath. And I don't think you want to use like an LXC or something through there. I think it would be kind of crazy. So body flossing is what I usually do. I catch the wire just as it was shown earlier, and then you come from above and you can use whatever you want. Never use a closure device. Personally, I don't do that. I know people have tried it. Manual pull, I pull as soon as possible. Again, even if the patient is fully anticoagulated, we don't have fellows in my institution, but we have techs, and that's what they're created for. So they will pull right away, and it works just fine. We never have problems because, again, in the foot, it's very superficial, you're over bone. Once you're in the calf, everything is moving, you don't have any control. It's much more difficult. You know, sometimes I put a blood pressure cuff up. You know, I haven't had problems so far, but God only knows what will happen next time. That's it. Thank you.
Thank you very much. So we're going to go ahead and get into our live case. Dr. Chamberlain, Dr. Woolley, could you guys come up to our panel? We should have Detroit online now. We're a couple of minutes late. So we have Dr. Tom Davis from Detroit. Tom, can you hear me? Tom, can you hear me? Can we get audio? Audio. Can you hear me, Tom? Can you let them know that we're live? Give us just a second. Dr. Walker, I was noticing when you were doing your transcollateral access, you had a crossover sheath in the popliteal artery. Do you get antegrade access?
Yeah, I would always prefer in that case an antegrade access. I try to get down 4, and then I would use a very flexible wire, one perhaps with a nitinol shaft, and a very flexible catheter to follow, because you really don't want to ding the collaterals. There was one comment I wanted to make earlier on some of the things that were said. This Cook sheath is actually a 2.9 French sheath, Cook sheath. It has an outer diameter that's equivalent to a 4 French catheter, but sheaths are measured by inner lumen, not outer lumen. So it's 2.9 French, and they have developed a series of 18 thousandths wire compatible catheters that will fit through that. And so you can continue to give drugs and antispasm drugs. And you can also, if you exchange, once you've crossed the lesion, to an 014 wire, they actually have a balloon that will fit through that 2.9 French sheath that goes all the way up to 4 millimeters and is quite long. So industry has listened, and they're giving us better tools to treat cases from a pedal access.
And then I want to show the IVUS, okay?
Okay, I can hear somebody speaking still. Are you guys ready?
Almost online. We're just trying to solve this audio issue, which happens with our live cases. Do we have any questions from the audience at this point, since we have a little downtime?
Can you turn this up? Can you turn this up? I can't hear.
Go ahead, start talking.
There we go. We can hear you now. Can you hear us, Tom?
Yes, I can finally hear you guys. How's everyone doing in Chicago?
Wonderful. Thank you. I have with me Dr. Craig Walker, Dr. Tom McNamara, Andre Parp, Mark Woolley, and Jack Chamberlain.
Well, gosh, all my mentors. Me being a young whippersnapper. Anyways, what we have, I'll present the case real quick that we have. We've been doing a little work while you've been, while we've been waiting here, but can you hear me? Can you guys hear me?
Yeah, we can hear you.
Okay, good. So this is a 58-year-old female who's had previous bypass fempop on the right, and she came in because she was having some claudication symptoms, very little activity, only about 50 feet, and she was also having some nocturnal rest pain at night as well, too. Her toes were very ruberous. She noticed that they had turned dark, discolored lately in the last couple days when I saw her. Her ABI was 0.5 on the left, and so thus prompting her, us bringing her to the table here. So we have some initial films here. I'm just going to go up. This is what we did, was come up and over, and you can see the totally occluded SFA with some reconstitution into the Hunter's Canal there. And not surprisingly, with her more critical limb, we think that there's going to be something below the knees. So we did a little bit of a runoff here. You can see not really great flow down there, but I think we have a little bit we have a digital subtraction down here now, and you can see there's going to be probably pretty significant disease down below the knee as well, too, that we're going to have to treat. So, I think the next picture is here. So what we've done is we started crossing this lesion while we were waiting. We used a Vance, I don't know if you can see this very well here. And what it is, it's a 1-to-1 turn torque. It's got a little stainless steel tip on the end. And as you can see, as you rotate it, what it'll do is it sort of bores through that lesion, find some microchannels and get through there. So what we did was we were actually able to we got through and we got to the distal cap and we couldn't cross back in. We tried wiring. So what we did was we brought a re-entry device down there, and we have the IVUS portion of it right here. So I'm going to show the IVUS portion of it. We're just going to do a pullback from the distal portion of it. So can you go to the IVUS there?
Hey, Tom, real quick, we can't, okay, there we go. All right, never mind.
Okay, let me see where this is at.
Now, Tom, was there a stump in that SFA, or was it a flush occlusion?
Yes, there is. There was a little bit of a stump, getting a little bit of stuff. So this is the distal portion, as you can see, where the SFA is. And so we're just going to pull back here. And as you can see, we're really true lumen here. A little bit of calcium there. But as we're pulling back, you can see a collateral right there, and that's where the distal end was. And so we're pretty much within the lumen all the way back here. We got a little bit of a perivascular hematoma there from probably a little bit of wiring, but overall this looks like it's pretty well within the lumen itself. And so there's the proximal end. As you can see, that's in the common femoral, and now we're coming in the sheath. So we're pretty comfortable that we crossed this and pretty well within the true lumen. So what we're going to do here is, because it's a long segmental disease, it's got a little bit of mixed morphology to it. It's got some calcium, looks like significant fibrous plaque, and what you weren't able to see when we were crossing this, we had a couple spots in there where we had to do a lot of manipulation to get it through. Just want to make sure this wire's not bent here. And so what we're going to do is we're going to use pathway here. I think there's multiple modalities that you could use here. What I'm going to do, could you give me another wire? I'm going to change this out. Could you give me another wire? That wire, yeah. So what we're going to do is I got a little bit of a bend in the wire here, so it's not much, but I think with some of these atherectomy rotational devices, if you have any bends in them, I'd rather change the wire out now rather than suffer the consequences after I get done. So asking the panel, how would you, how would the rest of the panel do this? Or what's their thoughts?
Tom, real quick, we had a little bit of issue when you were switching back and forth from the angiogram. So is there any way you could show that Viance catheter again? Because I know you were talking about it, we just couldn't see you.
Sure. Tell you what, here's the Viance catheter. Well, Mike, if you can get close on it. Mike, can you get close on this? Mike, there we go. Can you move the camera down a little bit? There you go. So I'm not sure if you can see this very well, but this is the catheter and this is the tip on it. And it's a 1-to-1 torque. And so this is the catheter itself, and this is the torquing unit out here. And you can move this as it goes on. It's got a little bit of a sheath here on it. And as you torque the catheter, it'll move through the lesion itself. So this is the torquing unit here, as you can see. And
what kind of wire do you use with that?
I just use an 014 wire. I usually use a hydrophilic wire just to go through it. I think it seems to work best for me, but I think most 014 wires work through this. I think it's just whatever your favorite 014 wire works on that. So we're going to change this wire out real quick. What I'm hoping to do is get this SFA done, and then we can maybe attack something down below the knee to try to get something better to the foot. Why don't you go ahead. So what I did was, after we got through here, try to take some, so you can see this is the initial pictures here. This is through the catheter itself, through the quick cross. So you can see there's not a lot of stuff going down there. You can see the perineal, you can see a distal pedal branch there, and maybe a little bit of plantar vessel there. Okay, hang on just a second. That's coming down there. So let's see it. So we're going to bring this down here. Go ahead. Come on down. Looks like we're in the perineal right now. Keep going. Good. Stop. So we'll put a new wire down there. Like I said, I just had a little bit of bends in there, and I think that's where, especially with what we're going to use with Pathway, I think if you have a little bit of bends in there, the problem ends up being that when you're trying to take the device out, you frequently lose wire placement down there. So if you have a problem, you certainly don't want to be losing wire. Let's see it. Flo.
Tom, did you notice any calcium in that vessel, or is it pretty soft plaque or fibrotic plaque? What did you think as you were going through it and with the IVUS?
It's sort of mixed morphology. Like I said, we got sort of in a mid portion there where we had a little bit of a difficult time getting through there. We had to put a little bit of force on it, but fortunately we stayed within the lumen. And then on the IVUS, as you can see, there was some calcium in that area. I don't know how much you picked it up, and I can't unfortunately pull it back there, but there was some calcium in there and mainly mixed morphology, but certainly was, if you look on the virtual histology, it was mostly fibrotic. We had a bubble.
Tom, how deep were you when you took the angiogram, the subtracted angiogram? Because it looked earlier, the subtracted I know was from up above, but then that second angiogram, it looked like the posterior tibial on the subtracted angiogram was the nicest of the infrapopliteal vessels. Do you think it's possible you may just be beyond the origin of the posterior tibial when you did this last angiogram via the perineal?
Let me show you right here. As you can see, Craig, the dye comes from above. This was through the quick cross that I had going down through there.
Yes.
So you can see the dye starts above. It doesn't reflux up. So it starts above. So I was above the posterior tibial. I think it's just, there's minimal flow. I think the outflow is poor, and certainly the inflow is poor. So this is where through the total occlusion at the popliteal where we did this. So the posterior tibial is open there, and it looks like the perineal is open there too. It fills from above and below, so there's probably some hemodynamic lesion there as well. And you can see the posterior tibial filling here, but it sort of peters out right around just above the ankle here, as you can see right there.
So I'm going to
see that? So, and this is why, the lady has rest pain as well too. So, certainly not because of that SFA lesion.
So Tom, I'm going to turn it to
and
our
then this
panel.
is the picture of the foot there, Craig, so you can see that. And this was, again, through the 018 catheter. You can see the perineal's open there, and it gives a little bit of collaterals off. And like I said, I think you can certainly see a pedal vessel there, and I think you can see a little bit of the plantar vessel there as well, too. Do you guys agree?
Yep. Tom, I'm going to turn it to the panel and ask Tom McNamara, once you're through this, how would you treat this? Would you angioplasty stent this? Would you hawk it? Would you jet stream it? What would you do?
Well, I just got done hearing Tom Shimshak's presentation with the Jetstream, and I must say that's an attractive concept. Prior to having heard that, I probably would have considered lasering it and then plastiing, and not a particularly popular combination, but one that appeals to me theoretically is to laser, to debulk, and then to use the cryoplasty following that because of the theoretical and I think some proof that it decreases the incidence of restenosis. I currently try to avoid stenting.
We call that fire and ice, laser and cryo.
There you go.
Well, I think that's every one of these, this is a lesion I think you can use multiple modalities on. I think it's whatever you're most comfortable with. We decided to use, my sort of algorithm on these long, bulky lesions when they're total is, so I do like Pathway, and it's, I think because it does have, especially the newer device, I think they've improved the shaft a bit, and it goes through lesions better. It's a little bit larger of a distal tip because it goes 2.4, you can have the 2.4 to 3.4, so I think it does do a little bit of debulking. I think it's all technique dependent. We're going to hopefully show you the proper technique here. So anyway, so we got the device. You can see it right there at the distal tip. We're going to use the small blades here now. And we got good flush returns, so you're going to go nice and slow. And again, I think the key on any of these things, whether you're using laser, whether you're using pathway or any other atherectomy device, it's really, the key is letting it, as I've heard Craig say so many times over and over again, let the device do the work. And this is what we're going to do here. So we're letting it go nice and smooth, and we got really good flow. And I think you can hear the pitch there too, where that pitch doesn't go down. And you got some pockets there where it's a little bit more open. You'll see it wobble a little bit, and that's what we have. So we're going to go slow. So what we're going to do is now when we're getting that area there, we're going to come back a little bit, let it clear, and then we're going to go back down. Nice and slow. And it's going to keep on going, keep going. Nice and slow. There you go. So you can see it sort of gets some areas there. And what we're going to do is we're just going to pull back here, let it clear out a bit. There you go. Push through again. I think this gives allows the device to clear a little bit. So that's where it's working there a little bit. And you can see the pitch changes a little bit because we got a really tight lesion here, obviously. We're going to go real slow through here.
Tom, what size device are you using here?
This is the Navitus to the Jetstream XC. It's a 2.4 with the blades down, and when the blades go up, it's a 3.4. And as you can see, it's the nice thing about it is it does allow you. We're coming down through here very slow. Okay, keep going down. It does have a little bit of a retractable handle here, so I can, when my badge gets a little hot, I can hide behind the fellows a bit. Slow down, because you can hear that pitch change. So we're going to come back a little bit. We're getting towards the distal outflow here. Okay, keep on going. So we're going to have to go real slow and let this device really do its job down here. So you can hear it changing pitches and so what I'm going to do here is it's having a little bit difficult time crossing here. We're just sort of putting pressure on it and coming back a bit. And so now it's going to cross here a little bit easier. So now we're down through it. As you recall, right around Hunter's Canal is where we had this, where it was crossing. So I'm going to bring it back here. And we'll go blades up. Now sometimes you can Rex it on the way back. I sort of just cut back and so I can hear if there's any spots where I've sort of not debulked the area, and I may work on that area a little bit more. That's it.
So Tom, one of the advantages obviously of the Jetstream is the aspiration. You don't really have to, most of the time you don't have to use distal protection. How do you feel about that?
Well, I think I don't use distal protection with this at all. I know if I want to hold the bag up here. So you can see here, I don't know if you can get the camera. No, just lift the bag up. I don't know, can you get the camera over here? Pull the device over. You can sort of see as Paul's wrecking my equipment here. I still have to do another round, Paul. So there's the bag. So we may have to clear this out again. Paul, can you just start it up and see if it's, maybe we don't have to. So that's the bag there, as you were saying, sort of. And I think, the only data that we have on Jetstream is Professor Zeller's. And he had a core lab with his, and he had somewhere around 170 patients on core lab. He had no distal embolization. So, so I think that, and I don't see, I think most of the distal embolization that I theoretically see is more spasm, because as soon as I get nitro down there, it really does take care of it. So now we're going to go on to the bigger blades. It's just a button click here, and it goes to the maximum tip. And so we're going to go, and again, we're going to have to go real slow here. And sometimes it's difficult to get through this thing with this. As you can see, it sort of really will bog down quite a bit more. And so we're coming nicely through here so far. And the key here is to really watch the aspiration, which I always look down there and make sure it is aspirating adequately, and it really is. So we got a good aspiration. And what it does is it's a 30 cc's per minute aspiration. And we're going nice and slow here. You can hear really a change in the pitch. I suspect we'll get it down below where we had the problem with the pitch change there. Okay, let's slow down. So we're going to back away just a little bit, let the device work. And sometimes what I'll do is, if I have a difficult spot here, just let it sort of sit there. And that's what we did. So now it's through that area. We go nice and slow again.
While you're working there, Tom, I'm going to ask the panel, in terms of distal protection, when would you use distal protection? When would you not use distal protection for any type of atherectomy? Is it sort of all comers? You always use it? Sometimes? What do you guys think?
Well, I'll let you guys answer, and I'll answer that.
I use it for all atherectomies. Sometimes I even use it if we don't do atherectomy. I mean, we've seen distal embolization even with balloons. For Silverhawk, Spider works great. Spider doesn't work so great for Pathway. For Pathway, you can use an Embo Shield, NAV6. You just take it off the wire, put it on a Viper wire, and it works great. I just don't do the only atherectomy device that I use without distal protection is the rollerblader. Everything else we protect, and we consistently get stuff out of it. So that's why we use it.
Mark, what do you think?
Yeah, I almost agree. Exactly. Yeah, if we're going to use atherectomy devices, we're using distal protection universally. But I think this is impressive. I think in terms of the aspiration. But the question is, this is time consuming. And is it any better than going down there with a glide wire? I'm in the false lumen. I think 70% of the time. So we're going to cut the false lumen. I guess it's okay to do that, but I mean, the false lumen is the media. The media is ideal space because it doesn't have any atherosclerosis. So I think ballooning the entire thing, stenting, takes half an hour and you're finished.
So Tom, that was a good point that Mark brought up. Let's say you did IVUS and you saw the entire vessel was subintimal. Would you still do Jetstream or would you use something different?
No. Okay.
Nice. Got a vessel
okay,
there.
I heard the panel's quiet here. I was listening for a bit, and so we're done through with the blades down, blades up. So what we're going to do is let's see it. We're going to take a digital subtraction here, see if we can get the whole thing in there. Okay, go ahead.
While you're doing that, this is Jack here. I did a case very similar to this last night. Put a filter down, and I couldn't get the filter back through the Trailblazer. It was so full. So I just, when you get blades up a long segment, I just feel more comfortable. There's just so much debris. Even though a lot is probably being sucked out, I think there's a lot that gets loose. I don't know if it's clinically indicated or clinical stuff, but it fills up the filter.
Jack, you bring up a great point. We don't have a peripheral distal protection device. We have carotid distal protection devices, and carotids are typically stenotic lesions, are typically short. These are typically long occlusions. When I use distal protection, it's more a clinical circumstance than anything else that dictates that. I do a lot of laser. I don't typically use distal protection there at all. But where do I think you have to use it? When it's truly critical limb ischemia, when you have one vessel runoff, I think those are cases where any error is catastrophic. And I think we clearly need development of better and cheaper distal protection devices aimed at peripheral distal protection.
And maybe we don't need as tight a weave on the filters. Maybe the carotid or the coronary level is not really necessary. I keep asking for a cheap $100 filter, but no one wants to make that.
And a bigger bag.
Now, Tom, you never went all the way down there with the Jetstream, correct?
We've already gone down. We still have I couldn't really get with the 3.4 all the way down there. As you can see, we're just it just fills a little bit distal. We still got a distal lesion there, so we're going to balloon this. What I'm going to do is I'm just going to take it's a 300 balloon because it's such a lengthy lesion here.
You can definitely see the calcium
300
now.
balloon with scoring balloon. What's that?
You can definitely see the calcium now that you remove the thrombus. You see, the boulder type lesions there, and you see those the calcified lesion in the adductor canal as well, really uncovering a lot of that plaque.
Well, I've sort of heard, just keep on going, people's thoughts on distal protection there. You know what, I truly think that when I see, stop, you're already going on there. I think you got some there's mobile plaque elements that I like, that's what I call them. And with these mobile plaque elements, I think are calcium, thrombus, things like that. And I think you can see on angiograms, if it really looks very calcified, very shaggy, I think those are going to be highly embolic when you go ahead and put devices down there. I think if you do devices properly, slowly, with good technique, whether it be any of the atherectomy devices, I think you have less options or problems doing it. And I think the other thing too is what's clinically relevant. I hear everyone say, well, any little piece of material down the foot's clinically relevant, but if you look at the studies that have angiographic core labs, there's very low incidence of distal embolization on follow-up angiograms. I think it was running 2 or 3% in definitive LE. Like I said, in Zeller's here where he had a core lab, he had 0%, I think it was, or 1 distal embolization. So I'm not sure how much is really clinically evident in that degree. So I sort of pick and choose what I use my distal protections on in terms of if I think it's sort of those mobile plaque elements, as I said, with thrombus or calcium, or if it's just something that's more stable, like even if it's a restenotic. I think if you use the device properly, I don't think you really see a lot of clinically relevant distal embolization.
Now that you're up with your balloon, let me ask you a question. One of the points that was brought up by Dr. Woolley was, let's say you IVUS this and you were in subintimal plane for a large portion of the CTO. Would you still do jet stream, or would you use a different method?
Well, since I'm never subintimal, I don't know how that's a relevant thing for me.
Sure, you're not.
Anyways, I think, at least my thinking is looking at all these IVUSs. I think that subadventitial plane, the adventitious sort of bends away and the plaque is not. So I really don't think you get on a rotational device much debulking if you truly are subadventitial. Now, if you're only in subadventitial spaces, a short area in there, I don't think it's a big problem. And I think when you do have those subadventitial areas, especially if you're using a rotational device, I think the patient does have pain when you're going through there, so you'll know it. And that's where I think more directional atherectomy, if you're going to use it, works better. I think laser probably works better there because the contact area, you're not really with a lack of rotational aspects and sort of dottering it. So again, I think if you use the devices correctly, I don't think you have a problem. Down. So.
Yeah, I'm not as good as you, Tom, so I do get subintimal quite a bit. So when I do that, though, I feel more comfortable using directional atherectomy because then I know exactly where I'm cutting. I cut away from the into the plaque more than away, and I kind of feel a little bit more comfortable about it. What do you guys think? Sure. For long CTOs, if you're going to do atherectomy.
I like the same thing. I think with IVUS, when you see that you're in the middle all the way down, I think your options are a little more broad. I think Pathway works really nice. And
IVUS is
Silverhawk as well.
Yeah, the IVUS is so nice to have that because you know exactly where you are.
Well, it's going to be interesting to see when we have the devices with imaging on them for atherectomy, how much it helps us and how much more confidence we have with that. I know using the crossing devices with OCT, it really does help me as I've gone by really truly stay within the lumen itself and things to that degree. So, and I think in looking at it, if you could do atherectomy with not damaging the medial layer or going into the media or anything else to that degree, really sticking to the disease, I think you're going to have a much more successful atherectomy too as well, and then hopefully results. So at least that's what I think you're going to have.
That's what I was just about to. So you said that was a 300 millimeter, so that's probably the Pacific? The six,
Pardon me?
Was that what looked like a 60 by 300 Pacific?
It's actually a 50 by 300 VascuTrack.
VascuTrack. Okay.
So it's got the dual wires on there, as you can see. On the floor here, you can sort of see the two wires there as it's coming out. So what it does is it gives a little bit of a scoring mechanism to it. I'm not sure how much that helps. I think it does, but I think the other thing, I'm not sure how much it helps after atherectomy, but the thing it does for me is I have a 300 balloon, which I like, and so I think it's nice to have a 300 length for these long, bulky lesions, because I have a hard time. Let's see it just a second here. So we'll see what. That's looking better. We sort of got a little bit of a ragged area up top, but let's see what we'll try to get a panned out view of this. Let's see it. You may have to put a little bit more balloon up there top. So go ahead, Cindy. No. We're just going to do this. So,
There you go.
the top up there, it doesn't look that bad there. And let's see down here. Let's see it. Okay, go ahead and take a picture. So we get a distal aspect here.
That looks really good.
So I don't think it looks that bad. Would you guys touch up any areas here? I'll show you the proximal area again.
Yep.
What does the panel think? Would you do anything else there?
I would be inclined to, yeah.
Yeah, I would use a 6 millimeter balloon. I'd stay incredibly low pressure, and I'd stay up for a long time. But I think I would use a 6 millimeter balloon, and I'd stay very low pressures, perhaps 3 atmospheres. It looked like you had full expansion. Just let it sit for about 3 to 5 minutes.
Okay. You want to give us a 60 by 200? How can I say no to Craig there, huh? So I think you're right, Craig. I think that distal outflow I'm still a little bit worried about. Even, I think I really like to make the distal outflows and the proximal inflows really nice, because I think that's where your problems are going to end up being. The mid portion actually doesn't look that bad. So we'll put, I'm not sure if I can do it 4 to 5 minutes though, Craig.
I think one of the things that we learned in Cello trial, but other atherectomy trials I think are also showing, is that one thing atherectomy does do is grossly change the compliance of a blood vessel. And it does typically let us dilate at much lesser pressures and end up with lesser dissections. And I think that's why I would go. I don't think I would go that big without some form of debulking, but it looks like you've gotten pretty nice debulking here, and I bet you get a nice result.
Tom,
so what I'm going to do before we put the balloon in there, we're going to take a picture below the knee. And actually, the runoff looks a lot more brisk, obviously.
That looks really good.
We're going to take a picture of the foot now. And we'll mag this up a bit so let's see it.
Tom, just to back up a second, that last picture at the adductor canal, you were not able to cross that segment, right, with the blades up, is that right?
Yeah.
Because you can tell the difference after the balloon, where you were able to do the blades up. After the balloon, it looks very good, but the die column is less across the adductor canal. I think it really kind of shows the benefit of debulking before you balloon.
Yeah, I didn't hear the first part of that, but
you weren't able to go all the way through the lesion with blades up, right?
With the atherectomy, with the pathway, I was able to do the blades out. Blades, yeah. We were able to do the 2.4 blades, but the 3.4, I wasn't able to get all the way through that distal lesion. No, because it kept on just. Okay, let's go. So we're going to put the balloon up, and then maybe we can talk about the distal aspect and see what everyone would do. Get everyone's opinion on that. We'll do. So, Craig, what's your definition of low pressure?
Of what?
Low pressure.
You said you use incredibly low pressure here.
What it would take to fill the balloon and not have a waste, but I would try to go 2 or 3 atmospheres. I think you can do it here. Then my second question is going to be, are you going to go open up that posterior tibial after?
I'm going to try to, absolutely. I think there's single vessel runoff here with the perineal really filling it, and the patient doesn't have a wound, so I'm not. I think if I left it with that, I wouldn't feel too uncomfortable, but since it was rest pain, but
Another
it's
good
gonna-
option that I like to use after atherectomy if I have calcified lesions is a plaque modification angiosculpt balloon. I think it has that double helix, has the wires, and it works really, really nicely in calcified vessels.
The other thing to consider, though, is to go back with the pathway blades up over that last segment you couldn't cross before. Now that you can get down there, all that stuff, the balloon that's probably recoiled, you probably get rid of some more debris in there and be more successful. You still got a waste.
Well, this is a 6.0 balloon, and we're at 2 atmospheres right now. So I think Craig's point, and I think the point of debulking is that you really don't have to have much pressure. It's the amount of pressure that you have to have is really directly proportional to the radius of the opening squared. So if you look at that, that's we have a very good opening. We've debulked quite a bit, and we don't really need to have high pressure to actually get that balloon open there. So which I think is good. So we'll try it. I know we don't have too much longer, so we're gonna leave the balloon up, and hopefully just a couple minutes will work for us, and then we'll take a picture of it, and then we'll see if we got any more time. We'll try to go down below the knee and get that posterior tibial aspect, see if we can get something in the PT there. Because it looks like now there's a nice plantar. So I'm going to get, how would everyone attack this? You can see the PT is open up to that area, and it looks like down below in the plantar there's there. How would everyone cross this?
Yeah, I would take an angulated view and see if you can see just the area, because it's hard to see right here. The collateral's in the way, but I would take an angulated view. If it looks good, I would get in there with a crossing catheter. I would use a fairly high tip penetrance wire and cross. You already have this interior out. It might also be an alternative because it may help you avoid the collateral.
Mm-hmm.
Actually, another thing which Miriam Otarjame has introduced me to is going bigger and blunter, going with the 035 quick cross and a stiff wire inside. I personally like the straight stiff glide wire. And that goes to what you were saying earlier, Craig, about having something stiff immediately behind what you're leading with. But to penetrate through that wall, it seems to me, the tinier the guide wire is and the stiffer it is, or the slipperier it is, the more it's like a thin needle that'll slide through what we don't want it to go through, which is the wall. And so I think there's some merit to non-slippery and broad and not sharp to try with. And sometimes it'll go amazingly easily straight through a relatively straight segment.
The other issue, though, is sort of what you brought up, Tom, is, should we even treat that posterior tibial artery at this time? If there's no wound, this is probably going to be a significant amount of improvement in symptoms of the patient. So do we really even need to, go down that path? Because it's most likely going to restenose in a year or 2 years, and we'll kind of start that cascade going. So the question would also be, should we just leave it alone?
Yeah, there's a great debate going on about that, but really this patient doesn't have too good vessel runoff to the foot. He's got a perineal that's got proximal disease. He has a posterior tibial. Later on, you're going to follow this patient. Mm-hmm. You want to know if they're doing better. If the only vessel that's open is the perineal, it becomes very difficult to know if they've got problems because you can't image it as well. I think if you hear and if you think you can easily cross this by taking oblique views, because that perineal is not normal either, taking oblique views, then you have at least one great vessel outflow to the foot. I know it's raging debate, just like there was raging debate about whether we should ever go below the inguinal ligament, just like there was raging debate whether we should ever go into the popliteal space, just like there was raging debate should we ever stick a pedal. But I really think that if you can do something with low risk, it makes sense. And this bar keeps being moved as to where we can intervene. And we used to say we absolutely only would intervene in an infrapopliteal for limb salvage. I'm not sure that's true. If you can do it safely and if you don't muck it up. And I think those are critical. So what I think would make it safe and not mucking it up is a good roadmap, an angulated view, making sure you clearly see your entry and exit target. You cross them. I really think there's precious little to lose.
Craig, I have a question relative to the wire. Tom raises a good question. Do you think you're more likely to stay in the true lumen with an 035 glide wire, or you think you're better off with a 014 or 018 in terms of these tibial vessels, like 2 millimeter vessels? Now, we routinely use 014s. But, and Craig I know is big on 014. But Craig, what do you think about the concept that Tom raises? Does the 035 stay in the lumen, true lumen, better than the 014?
Well, it's certainly less likely to go into the collaterals. I think there's no doubt it's less likely to go into the collaterals because you've got greater cross-sectional area. That being said, this is pretty short. I think you can see a finite stump into and out of this. And then I think you can steer this other thing. You can't steer a straight wire. And it's going to sort of go where it wants to go.
The straight part's a plus and a minus. The straight part keeps it more likely to stay in the lumen, so that's the plus part. You're right on the steerability. The other thing I'd point out is that proximally in that posterior tibio-perineal trunk, looks like there's a stenosis, which might look even tighter in the oblique view. And I like the cutting balloon on short proximal trifurcation lesions. I've had excellent durability, and so that'd be another way to improve the inflow.
I agree.
Well, what we're going to do is, I don't know how much time we have left here, but we're going to try to take the Viance down there, and we're going to see if we can actually go after that PT. Like I said, I wouldn't be too terribly, because there's no wound here and it was rest pain. I think this is going to solve our problem here with that perineal branch, but I think that, you want to grab that? I need a new glove, Paul. Oh, I need a new glove. And so I think that getting the, what we've got open is going to solve the problem that the patient has. But I think it'd be nice, I agree with you, Craig, to get that PT open.
So is everybody happy with that SFA? Would you guys leave it there? I think if Amir was here, where's Amir? If Amir was here, I think he would vibe on that SFA. But what do you guys think? Would you just leave it at this result, or put in a stent, or what do you think?
No, you raise a very good point. Yeah. No, I think that's a very good point you raise. My question is that there's a tremendous amount of surface irregularity on the intimal down there. That can't be good.
Put it over the wire.
So my question is, if you stented that, it would look better than your normal anatomy. So why weren't we stenting this?
Restenosis. Restenosis.
Hold on. Oh, go.
The other thing, though, Mark, is that if you follow this patient carefully, he probably won't just suddenly reocclude. He'll develop stenoses, and coming back and doing a follow-up angioplasty with a shorter focal force balloon on a restenotic area, it's an incurable disease, and I don't feel bad about retreating them. Frequently, they'll do better after the second treatment, and I think that's more true if they don't have a stent in.
Is the patency better?
I think the patency post-treatment of a restenosis in a native artery is better than patency following treatment of in-stent restenosis. That's all potentially changeable with the laser, et cetera, but I think that's true at the moment.
Okay, so I'm just going to get that old other picture up, see where the PT comes off. And let's see here. There we go. Okay, that's it. Floor. Just floor. So I got the Vance down there, and we're going to try to wire the PT. Hold it right there so it doesn't come back. I think I'm going to need a smaller bend on this thing, so it's not going to go through there. But too big of a bend on this. Take a picture here so we can see exactly where go ahead, take a picture. So we'll take another picture here just to see where that, there it is, okay. It's up a little high, let's see it. We'll see if this will come down into there. I think I'm going to need a smaller bend still, but yeah, so we'll just bring this down here just to give myself a little.
Tom, looks like we're over time now, so we're going to go ahead and leave you to this posterior tibial artery. We really thank you from the bottom of our hearts for being here today and presenting this case for us, and look forward to seeing you tomorrow. Thank you so much.
Absolutely. I'll see you guys tomorrow then. I'll be down there. Actually, tonight I'll be down there, so hopefully I'll see you guys partaking in some liquids.
Yes. Safe travels. Thank you very much.
Okay, guys.
What's that? I don't know for sure. Maybe 300-400 miles. Be my guess.
Next, I would like to bring to the podium Dr. Desmond Bell. Now we're going to really, Dr. Desmond Bell is the founder of the Save a Limb, Save a Life Foundation. Really honored to have him here today, a podiatrist, and we really want to hear what he has to say about working together, and that's what it's all about interventionalists. It's not just about doing the procedure, it's also about wound care and following up these patients, and that's half the battle, because I see these patients all the time, and I say, okay, I walk away, I said, now I'm done with you, it's now the job of my podiatrists that are really responsible to really take it to the next level and make sure that wound heals. So I'm going to give it to Dr. Bell. Thank you.
Thanks very much. My pleasure. Set that down there. Hey, thank you all. And I will tell you, I know I'm going to be preaching to the choir here, but it's really great to be here. Very important message that we all have here, for sure. So my co-founder and dear friend, colleague, kind of made this off-the-cuff comment one day. He said, amputation should not be seen as a treatment option, but a treatment failure. And really what this speaks to is the fact that, look, we know that sometimes amputation has to occur, but so often it's subjective, and we've got to really move past this. And when I say that I'm speaking to the choir here, the take-home message I hope you'll remember from my presentation today is, look, we just saw this amazing presentation of technology being utilized in this esteemed panel here. These guys do this every day. They make me look good. But you know what? The majority of the people still don't get it. Primary care physicians don't get it. Patients, the general population, surely don't understand what this is all about. So we've really got to keep pushing as a group, not just individually. So I start with this. Everybody knows what this means, correct? Every October, we see pink everywhere. We know that. Yet there's so many more people that have PAD, not alone diabetes and non-healing wounds. So I know this is probably going to elicit some correct answers for a change, but I want to tell you, for the past 2 years, in me traveling around the country, speaking to medical professionals, I constantly ask this one question. Can anybody tell me when PAD Awareness Month is? See, I mean, that's the whole point, okay? And no Googling on your smartphones either right now, okay? That doesn't count. But honestly, in the past 2 years, I've had maybe somewhere between 5, but definitely under 10 people have gotten it right. So don't feel badly. The whole point is that we haven't done the proper job of getting the message out. And this is where our challenge is, because there are far too many people suffering in silence. Now, my colleague and good friend, Dr. David Armstrong, came up with this really innocuous little paper a couple years back. However, you probably have seen it by now, because this is really driving home this message. If you see that little red bar there, we're looking at the 5-year mortality rate of people who are suffering with non-healing diabetic foot ulcers. Now you compare it to other serious illnesses. You look at breast cancer, which we just alluded to. 5-year mortality rate is about 14%. Prostate cancer is around 6% now. The only really things that are worse than PAD and non-healing diabetic foot ulcers are pancreatic and lung cancer. And yet there's no outcry. A patient goes to their primary doc with a diabetic foot ulcer, and what happens? Maybe Keflex, come on back in 2 weeks. So we've got to do a better job at really driving home this message, whereas a woman shows up to that same primary care physician with a lump on her breast, and we know that the wheels are set in motion and the referrals are made to the proper specialists. So, we have to look at this in the same way. So we're going to talk a little bit about the roots of limb salvage. About 20 years ago, you really didn't hear about wound care centers, but now it's part of our jargon. Well, limb salvage has become this real popular buzzword, and now it's even shifting towards limb preservation. So we have to watch for, some of the marketing of this in a sense, because as I'm going to touch on in a few minutes, there are real disparities in the level of quality of care that's out there. Are people using this whole concept of limb preservation just maybe to further their own practice? The point is we have to really look at the guys who are doing the good work out there. But in the day of Lazarov techniques and Charcot reconstruction and wound care centers, limb preservation has really become a catchphrase now. So toe and flow is a term that you may have heard, Dave Armstrong again, Lee Rogers and George Andrus really termed this or coined this phrase a few years ago. And we did salvage this lady too. Both of her feet and legs looked like that. But really, Toe and Flo stressed the idea of vascular surgeons and podiatrists working together. Well, that paradigm has shifted because this is really before endovascular procedures truly emerged. So now we're at this point where, yeah, we have to include our cardiologists, our radiologists, as well as the vascular surgeons with podiatry. So you got to know the difference between the specialists. And again, not many people really are clear as to what an interventionist is, so we've got to continue to educate. And we've got to really look at, not only credentials, but really you've got to try and find out who's doing the good work in your community. And that sometimes is not easy, and sometimes feelings can get hurt in the process too. So I look at this patient of mine from a few years back, and I show her, I didn't black her eyes out on purpose, because I want you to understand the pain and frustration this lady was going through. And that's her foot. Okay, now one of my colleagues, a good friend of mine too, was seeing this lady, and all he's doing is putting Silvadene cream on here. And look, we've got to do better than that. And that's the point of educating each other about what can and can't be done, what is salvageable and what is not. So I say politics be damned. Well, I got her admitted, and I called on my colleague, Khatib, to come on and do a consult and see if we couldn't salvage her. Well, patient never told me that she had a cardiologist already. So this sort of set off the storm. Well, that cardiology group claimed that they did intervention work. Well, the problem is they didn't go below the knee. So, again, politics were there, and feelings were hurt, and in the chart, this doctor's calling me basically every name in the book. I don't know what I'm doing. And so this is kind of how I grew up in New Jersey, and this is how we handle this type of situation. And it's like, what do I know? I'm the podiatrist, right? Patient needs a BK. But the point is that, all she ended up losing was a great toe. And so she survived for a good 4 years with her leg. So that's why we do what we do. They said this lady was crazy. She wasn't crazy. She was in a hell of a lot of pain. That's the point. So really, we've got to get past this working in silos. You probably have heard this now over and over again. Well, really, silos are these information technology type phrases where they're talking about people who are doing their jobs, but they don't communicate amongst each other. So we've got to know what each other is capable of doing and really spread the word. So we are really a resource for each other. You come to a meeting like this, and hopefully you're doing some networking, and you're getting to know people that maybe can help you in your efforts. And it's amazing living in Florida, where I do. People come through, and people call us all the time looking for help, looking for answers. Who can I send my loved one to? So being able to pick up the phone is really quite important in getting patients to the right providers who can provide the right care and ultimately, preserve a limb, save a life. So I just want to quickly show you this. These are some old numbers, however, they're still relevant because it shows you what networking can do. So this was a supplement. I contributed to this. But basically, don't mind all the busy lines. I'll just tell you that yellow line shows the number of critical limb ischemia cases that we saw in our particular hospital in Jacksonville back in 2006. And the red line shows the total number of salvage cases that we did, which went up concurrently. You would think that the amputations went up, however, they stayed relatively flat. The point is that working together in a team approach, we didn't even have a dedicated wound care center in our hospital, but communicating really makes the difference. So overall, to boil it all down, our amputation rate for ischemia and ischemia with gangrene cases went from about 53% down to 21%. Nothing magical, just knowing who to pick up the phone and talk to, knowing who to work with. So how do you take action steps in all this? And a couple little tips for you. Really just become a champion. Become the person on limb preservation in your community. Let people know that you're not afraid to do this. Identify those who can help you in your efforts too. Refer to other providers who share in your vision. Become involved in other organizations like the PAD Coalition, our organization, Save a Leg, Save a Life. Become in your local diabetes screening. Start your own screening event. Do it at a local church health fair or something like that. You don't have to sit around and wait for somebody else to do it. Again, if you see the problem and you don't do something about it, then you're part of the problem. That picture was actually taken here in Chicago last Labor Day at the African Festival of the Arts. So just get out and you'll never know who you're going to touch, but just educate. You don't have to do hands-on screenings either. Just tell people about PAD. Talk to them about diabetes. Ask them if they've had somebody in their family who suffered from it. And really, that's all you have to do. Here's an example at the Jacksonville Zoo a couple years ago. The ADA has a step out. They probably have it in your community too. Volunteer. Just go and talk to people. That's all you have to do. So this is why screening is so important. And again, you probably have heard this ad nauseum by now, but it's certainly worth repeating. The American College of Cardiology, the American Heart Association recommend that anybody who's over the age of 50 who smokes and or who has diabetes should be screened for peripheral arterial disease. Because we know also we're not only helping reduce amputations, we're also helping prevent heart attack and stroke. So very, very important. And a little follow-up to this, the most recent issue of today's wound clinic focused completely on lower limb preservation. So I was happy to contribute an article to this. And so a couple little last facts. Foot ulcers precede 85% of diabetes-related lower limb amputations. 60% of lower limb amputations occur in persons with diabetes, and 5% of people, or 5% of diabetics will develop a foot ulcer each year. So that's a lot of people. And hopefully we made up on some of our time. So thank you all very much.
Next, we have Dr. Garofalos, who's going to be talking about biological dressings and negative pressure.
Thank you. Thanks, Jaffer. Actually, the negative pressure I'm going to talk about tomorrow when I talk about it in conjunction with HBO, so be sure to come back tomorrow. Some advanced modalities that I'm also a little short for this. Advanced modalities utilized in wound healing is something I want to cover. I'm at Jesse Brown VA here in Chicago. We have the largest hospital-based wound care clinic or podiatric clinic in the VA system. We see 15,000 patient visits a year there. And being an inner city hospital, you might imagine we get the worst of the worst and comorbidities like you can't believe. Their pharmaceutical lists, their drug list is several pages long on the computer, not to mention what they use on the street. So we get that fun stuff too. So we tend to be pretty aggressive with our wound treatment in our program. I am going to talk about some products by name, so that's just for demonstration purposes. What are the goals of great wound care? Well, first of all, we have to get the underlying causes under control. I'm a strong believer in aggressive debridement. We have to adopt new modalities as they are developed, and we have to use the best products available, control the wound, and as Des said, save a leg and save a life. Now, it's commonly said that, you guys do the plumbing and then we do the wallpaper, and that's kind of the way that I envision it, because you guys make it possible for us to finish the product. And that's what we're going to talk about, using these advanced products to take it to the next level, because I believe they're the standard of care. So this is a quote by Margolis about randomized controlled trials have actually demonstrated that using these therapies, including offloading and great wound care, are absolutely the correct and the best way to go. So we have documented evidence that these advanced products, even though they're expensive, do work the best way in healing these wounds and are actually cost effective. There's PMA products, there's 510K products. This is just a little very wordy slide, unfortunately, talking about the very few number of top level products that have the evidence that tells us that they have the highest FDA approval. Apligraf, Dermagraf, or Granix have been around for well over 10 years. All the other wound care products out there right now have 510K approval, which don't rise to the same level of evidence. So I believe in using evidence-based products, using products that have shown a great track record. These are the two products that I want to talk about briefly, Apligraf and Dermagraf, because these are the next level products that we use to get these wounds closed as quickly as possible. Apligraf is a bilayered cultured skin equivalent developed in 1998 for VULs, then approved for DFUs in 2000. Type 1 collagen, it also has type 3 collagen. It comes from human neonatal cultures of foreskin, fibroblasts that produce the matrix, keratinocytes that help to produce the epidermal portion of the wound restructuring and of the matrix that we need for that wound to close. Dermagraf has been around almost as long, indicated for diabetic foot ulcers. It's a fibroblast component. It's indicated for full thickness diabetic ulcers. These two products used in our practice at the VA and in private practice do a phenomenal job of healing wounds quickly. We need to make sure, and this is the slide that demonstrates aggressiveness. Over on the far side, these are the things we all do for good wound care, over on the left side there. But if these wounds aren't closing after they've gone ahead and been revascularized, we now have blood flow going down to that wound, and after we free the wound of infection, freed of necrotic debris with our aggressive debridement, if they're not closing by 50% in 4 weeks with good controlled wound care, at that point we absolutely must go to the next level of wound care, which is these advanced products. There's documentation and literature to show that that is the right way to go. These articles have been published over the past 11 years or so, and they demonstrate the fact that the 4-week model is indeed a correct model to follow, that using that model is now the new standard of care, so we need to treat these wounds aggressively to get them to close. Here's what happens if we don't treat these wounds aggressively. If we treat these wounds for 4 weeks, we have nearly a 60% chance of getting them closed in a timely manner. If we continue to treat these wounds longer, for say several more weeks, we have less than a 10% chance of getting them closed. And what a shame that is, especially if all the work that has been gone in to revascularize these wounds or to free them from infection, the extensive debridements, if we're not jumping to the next level of care to get these wounds closed, we're actually doing a disservice to that patient. We need to restore the skin barrier. These are some of the things that these products do to help that wound close faster. We know that using these products, proven in literature, helps to close wounds faster. Sometimes by 30% faster, but it also prevents osteomyelitis and amputations. And we know that the longer the wound is open, the greater chance we have of something like this occurring. So our goal is to close that wound as quickly as possible. We know that in a product like Apigraph, as it's applied, study after study has shown that when it is used, it closes wounds faster as compared to standard wound care. So here we have a couple products that do a fantastic job. Here's a 60% increase in wound healing just by changing products. From going good normal wound care to using an advanced skin product, we jump from 39% to almost 60% closure rates. This is what we want to do for our patients. This is faster closure in a venous leg ulcer using Apigraph. We can close that wound in half the time. Isn't that great? That's exactly what we want to do. Now, there's a cost to these complications. That's why we use products like this. Amputations in the VA system cost as much as $75,000. We want to prevent that. These products are indeed cost effective. And there's article after article, again, that speaks to the cost effectiveness of these products. Yes, they're expensive to use, but if we can get that wound closed, change the quality of life, decrease the chance of complications, we've now saved lots and lots of money, billions and billions of dollars. So there are times that we don't want to, of course, use these products. If there's not good blood flow, if there's perfusion or lymphedema issues, infection, fibrotic tissue, we have to clear that up. They're not supposed to be used over tendon, bone, capsule, off-label. Of course, we do use them that way, but they're more different. They work not quite as well over those types of situations. Non-compliant patients, and believe me, in the VA situation, we have plenty of non-compliant patients. They create some challenges for us, and so we make sure that we do a little interview with our patients before we go and splurge and use these products on them. And of course, many of these patients are on medications. Most of our patients, as I said earlier, are on a long list of medications. Well, there's some medications that really don't work out so well when there's an open wound. They really don't help that wound close. We need to be cognizant of those medications and maybe alter their dosage or alter what the time frame is that they're on those medications in order to allow for wound closure. And I've just listed a couple of them here, some of the COX-2s, statins, which, you know, everybody should be on a statin, right? except if you have a wound. They're really not too good for wound healing. Lasix, tetracycline, things like that, they kind of slow down the wound healing process just a bit. So if we can alter those medications by dosage or by time, we might be able to get that wound closed. So, as I stated, wounds treated with the engineered skin and these products have a greater chance of closing as compared to what you might think is might be better, like recombinant growth factors or even platelets applied right to the wound bed. These products have demonstrated that they work better than those products that have been out for a while also. So, as I stated earlier, this is the new standard of care. I think aggressively this is the direction that we need to go. Thank you.
Next, we have Dr. Desmond Bell finishing up the first part of the afternoon session before we go to break in discussing stem cell therapy for critical limb ischemia.
Okay. Hopefully this will not be death by PowerPoint, okay? Just bear with me. When I tell you, I know something about stem cells. Don't call me the expert, but I know enough that I think I can deliver the message. The point of this really is that even though stem cells have been around for a while, and even though there have been trials that have been going on for at least 10, 15 years now, there's still so much that, it's still not there. So really, I love this quote, kind of really puts this in perspective. Whatever the mind can conceive and believe, it can achieve. Great line by Napoleon Hill. So the key concept here is that most of the stem cell research that we're talking about for critical limb ischemia revolves around intramuscular injection and collateralization. So basically, that's what it is. Most of the clinical trials that are out there talk about using stem cells and injecting in specific sites. So we're going to cover this. We're going to look at Cochrane reviews. We're going to kind of see where the state of things are. But let's before we get into that, let's take a quick review of what stem cells are, what differentiate stem cells are the two key characteristics, I should say, in stem cells that differentiate them from other cells. And you have basically the generic form where they're undifferentiated. They can evolve into something else later on. And then you have the type of cells then that can, under certain conditions, they can then morph into the appropriate tissue or organ-specific cells that have specific functions. In some organs, such as the gut and the bone marrow, the stem cells regularly divide, and they replace out the worn or damaged cells. And then, however, there are some organs, though, such as the pancreas and the heart, where the stem cells only divide under special conditions. So let's take a look at some of the types of stem cells that are out there. You have the hematopoietic stem cells. These give rise to all the different types of blood cells, your red blood cells, your B lymphocytes, T lymphocytes, natural killer cells, neutrophils, basophils, eosinophils, monocytes, and macrophages. And this quite busy diagram, basically you get to this point right here, and this is where they start to take either a left or a right. They can turn into either all the different types of neutrophils, eosinophils, et cetera, or your killer cells, your T cells. So basically, there's this whole process that occurs. And where are these cells found? Well, generally within the bone marrow. And that's where the source of much of the stem cells that we are using today for stem cell research and trials comes from. So just again, historically, just so you know some of the other type of specific stem cells that are out there, you have your mesenchymal stem cells. These give to a variety of cells such as your bone cells, your osteocytes, your cartilage cells, and your fat cells, as well as some connective tissue type cells. You also have your neural stem cells. There are basically three, your nerve cells, which are your neurons, and your other two categories, your astrocytes and your oligodendrocytes. Your epithelial stem cells, these are in the digestive tract and the deep crypts, and these give rise to several other type of cells, your absorptive cells, your goblet cells, your Paneth cells, your endocrine cells, and then your skin stem cells, which Dr. Garofalo just talked about keratinocytes a little bit. These are found in the basal layer of the epidermis and at the base of the hair follicles. So these give rise to your keratinocytes. And your follicular stem cells, can give rise to both the hair follicle and the epidermis. So you see, you have all these different type of cells that, they start out as neutral and then they become specific in the course of their development. So where's the difference between the embryonic stem cells and the adult stem cells? Well, in the perfect world, embryonic stem cells are great because they're pluripotent. That means they can differentiate into anything. You basically have a clean slate. However, with all the controversies about that, a lot of the research that's being done is with the adult stem cells, which are also great. The real key thing here, though, for the advantage of adult stem cells is that these are less likely to cause a rejection, especially when it's derived from the patient themselves. You have, among your adult stem cells, there is a technique that is involved that can actually transform the adult stem cells into that generic kind of embryonic type stem cells. So we call this induced pluripotent stem cells. So that's just for background information. So where are we right now? Let's take a look at the literature and the clinical trials. In preparing this lecture, I found out there are about 112 papers on PubMed. The Cochrane Review, almost non-existent in terms of stem cell research for critical limb ischemia. And there are approximately 30 studies listed on clinicaltrials.gov that are presently enrolling, completed, or have terminated. So, there's stuff out there, but where are we? Well, let's take a look. Group head by Moazami conducted a review of the clinical trials that have been done basically within the Cochrane Peripheral Vascular Disease group. And this is really discouraging when you look at it because they looked at about 37 different trials, and of that, they basically came down to 2 particular trials that fit their criteria. And these were trials that they used the bone marrow-derived mononuclear cells, the BMMNCs. So these were published back in December 2011. And if you take a look at it, as I mentioned, there were 37 potential studies, only 2 that fit the criteria. And of that, basically what they found was really not too encouraging. Basically, you had one study that used the intramuscular injection of the BMMNCs, and another group, study 2, used granulocyte colony stimulating factor as the key type of stem cell. So basically, what they found, to kind of summarize is study 1 and study 2. Study 1, no significant difference in pain or ankle brachial index with their group in comparing treatment versus control groups. The treatment group did show a better chance of not undergoing amputation, so that is positive. Study number 2, basically with the granulate colony stimulating factor group, there was certainly decrease in overall pain as well as total number of pain-free walking distance, so that could be significant. Smaller number of this group also underwent amputation, so there's something there, but statistically it's just not enough to support where we'd like to be at this point. So all is not bad in the world, however. So let's take a look at some of the clinical trials that are still going on. Let's take a look at some of the failures here too. To me, one of the most really frustrating ones was conducted a few years ago. They were actually in their phase 3 of their trial. That was Sanofi Aventis and a company called Vical, who they were working with. Their product was called Tamusi, which again was injectable, gene therapy to try and stimulate angiogenesis essentially. So they made it through phase 2, everything was looking good. By the time they got to phase 3, however, they discontinued the trial because they did not show any significance, they didn't hit their endpoints, and so that was quite frustrating for sure. Just as an aside, this company Vical had been projected to make probably at least $115 million by the year 2016 on royalties and some other incentives for this. So there's certainly some financial benefit to this as well. Astrum is another company that you may have heard of. They were motoring along. They had the Restore CLI trials going on. They were in their phase 2. Everything was looking good. Here they were talking about intramuscular injections of autologous tissue repair cells, which TRCs stand for stem cells and progenitor cells. So basically, again, things were looking pretty good. However, when they hit phase 3, something happened there. whether it's the study design or whether there's some other issues. Not quite sure, but they have since suspended their trials right now. Now that picture that you see right there was actually a young lady, a patient of mine, who had actually been to Thailand and received some stem cells. She'd already had a bypass at the age of 39, was told that there was nothing else could be done for her, went to Thailand, and unfortunately that did not work either, so she didn't have any good result with her stem cell result. The good news is we did have great results using endovascular techniques, so she still has all 10 toes 4 years later. Again, Astrum, their phase 3 trial, again, recently terminated. It really was a business decision. However, hopefully they'll reboot that. And again, here they're using bone marrow aspirate as the source of stem cells. Baxter Healthcare is doing a study right now. Lasordo et al. are using CD3/4 plus cells. Again, study size is quite small at this point. What's encouraging about this is that in both their in their pain and their amputations, the patients who are receiving whether low dose or high dose of therapeutic injections are doing better than the patients who are in the control group. So that certainly looks to be something worthwhile to follow. And this is both at 6-month and at 12-month intervals. So there's certainly cause for hope right there. Again, the amputation incidence was lower in both the lower dose and the higher dose groups. So kind of what Dr. Garafalos was just referring to when you're actively involved in some type of treatment, whether it's because of better wound care, whether it's because of the intervention, these patients are certainly doing better. Harvest Technologies, here's another one that's out there. Be aware of bone marrow aspirate concentrate again. Their phase 3 trial is ongoing right now, and this is looking pretty promising right now. What happens when somebody has an injury from ischemic tissue especially? Well, there's a release of bone marrow cells into circulation. It's the natural response to that injury to try and repair the tissue. So basically, here you go. This compound called SDF1 is released from ischemic tissue, and it recruits the bone marrow cells. The bone marrow cells in turn release their stem cells or what other growth factors they have, and the idea there is to begin repairing. So the bone marrow cells also release VEGF into the circulation to help stimulate the formation of new blood cells. So right now there's some real good promise there as well. Other noteworthy trials that are going on, and these are very, very rudimentary at this point. There's a company called Metastem. They're using the endometrial derived cells, and the thought process here is that every month as a woman has her menstrual cycle, these cells are involved in creating new this rich blood supply. So basically they're looking at the endometrium as a potential source for such cells for future therapies. Then there's also another company out there that's called BioHeart. They're looking to use adipose cells for the source of their stem cells. So, again, the take-home message here is, we may be on the cusp of some exciting things. There's certainly a way to go. It seems like it never happens on the timetable we'd like, but time is of the essence, and it looks like we are getting there. So, again, thank you all very much. I know that wasn't the most exciting topic, but thank you.
Thank you very much. It is caffeine time now, so we have snacks and drinks in the exhibit hall, and we'll be back at around 3:15, and we'll get started then. Thank you.
How are you?